And so if you could please give a warm welcome to Mr. Preston Alexander.
Thank you for that introduction. It's pretty much the only reason I'm here is because I have two first names. And I'm also much funnier in the newsletter than in person, so I apologize. And if it's not funny enough here, you can head there. But it's great to be here. All right, real quick, show of hands, who's really hungry, just so I know how fast I need to go. All right, just a couple people. So anyways, we're going to be talking a little bit about hospital finance. I'm going to try really hard not to make it boring, but I can't make any promises. Me and Ann hang out, and so I like to be boring also. And this is what we're going to be talking about today, kind of. I don't have slides like with these things actually on there, but hopefully you get the gist. So let's start with an economic foundation. Who's ready for the boring part? Yeah, Ben is. Okay. I think it's important to start here because we have to understand some of the dynamics that could happen in healthcare from an economic standpoint to really know what's going on with healthcare finance, with hospital systems, and why they behave the way that they do, and with health insurance companies, the so-called payers, but really claims processors as they were. So first up, market structure. So who remembers in economics class, like what free market is and pure competition and all that stuff, right? And then we have a monopoly. And then somewhere in the middle, we have something called an oligopoly, which is to say that a few firms control pretty much most of the market. Sound familiar at all? Something like that in healthcare? So we do have some version of that going on. It's more regional based from a health system perspective, because obviously, maybe one day, but right now, we don't have these huge chains that dominate across the entire country, but they're very regionally powerful. The BUCAs, on the other hand, dominate across the entire country. So again, framework, foundation for what's going on. It also leads to this next point, which is leverage. If you are a hospital that is a small rural hospital or a critical access hospital with 20 beds, how much leverage do you think you have in negotiating rates with Blue Cross Blue Shield, which has 80% of the market in your particular area? Who thinks you have a lot of leverage? Who thinks you have no leverage? Exactly. And the same is true on the opposite side. If you are a health system like Christus Health out in New Mexico, and you're the only game in town, how much leverage do you have to negotiate with the insurance companies? A lot of leverage or a little leverage? So this is a leverage game that is played on both sides of the equation all the time. This is one of my favorite ones, and I think a lot of people probably have different opinions about this. But let me ask you a question, and this is going to be a little morbid, so I apologize. If you had a heart attack right now and fell on the ground, how much would you pay to have someone come and save your life? Who would pay $100? No one? All right, who would pay $1,000? $10,000? $100,000? All of the money you have, right? You would pay anything to have your life saved or the life of a loved one saved. Now we have a flip side of that, right? Who would pay the same price for an MRI? $100,000 for an MRI? No way. So yeah, we have this interesting elasticity issue in healthcare, whereby an MRI, you have a lot of shoppability, you can go, it's not urgent, et cetera. But if you have a heart attack, what do? Does someone say, hold on, ambulance, let me call around and see who has the best pricing in town? Stay right there, right? No, you just go. And then there's an effective inelastic element there too, when people just don't know how to go different places, where to go, geographic issues, et cetera. Supply and demand. So this one everyone knows about, right? If you control the supply, so there's low supply, and a really high demand, how much can you charge? All of the money, right? We'll go fast past that one. That's a good lunchtime saver. All right, value exchange. Does anyone here know what the value equation is that we talk about in healthcare? Shout it out if you know. Anybody? What's that? Okay, that's one. I haven't heard that one. So a lot of people talk about quality divided by price equals value. But there's two problems with that. Problem number one is, how are you defining quality? We have this discussion and this argument all the time. We have MIPS reporting and all kinds of different things. We're trying to HCAHPS, we're trying to measure what quality is. But quality to me and quality to you might be a totally different thing. Not to mention, where do we attribute the quality? Is it the doctor? Is it the hospital? Is it the ambulance? Where's the quality coming from? And then we obviously have a price issue. So I would argue more than a value exchange, we really predicate things based on cost versus quality or price or value at all. So, okay, economic lesson over. Thank you for indulging me. I really appreciate it. So, boring part is mostly over because we got to talk about the system now. Now that we have this sort of macro perspective of some economic principles that may or may not have sounded very familiar in healthcare, now we can talk about it in terms of our system. Okay. So what kind of a healthcare system do we have? Is it a public good? Or is it private enterprise for some other purpose, namely profit? Realistically, we have both. We really have a system that I think walks in two worlds. And it walks in two worlds as a subsystem of a much larger thing. That thing in America, our economic system, is, you can say it with me, capitalism, or some version of capitalism. In our version, it's really a little bit more like what we could think of as a profit maximization system. The system is designed, and we all do our best work to try to make as much profit as we can. And by definition, when you're working on profit maximization, more and more money goes into fewer and fewer pockets. So does that sound familiar? Consolidation. The BUCAs, 5 health plans controlling or have about $1 trillion in revenue going into 5 companies that are the largest companies in the entire world. That to me sounds like a profit maximization system. Now, okay, so we have this macro system. It's based in a lot of that economic element that we just talked about. So we have this profit maximization capital system. Within that, we have the healthcare system. And so we've given these for-profit, publicly traded entities control over access to the subsystem, to the healthcare system. Their incentives and their goal, and in fact why they exist, is to make as much profit as possible and to deliver returns to their shareholders. Now, underneath that, we have our hospital health system. I know, there's a lot of systems, right? And those are nonprofit or tax exempt. And we have told them, you are a public good. You have to abide by EMTALA rules. You have to take care of everybody. Medicare, Medicaid, doesn't matter. Indigent. I don't like that word, but a lot of people know it. So people who can't pay, right? So it sounds like a public good. And we say, well, they don't have any shareholders, but what are they also doing? They also necessarily, because they operate in this for-profit system, because they are battling for leverage with for-profit entities, have to make as much money as possible. Because they have to consolidate. If they want the leverage, if they want to get rates up, if they want to be able to pay for rising costs of everything, they need their revenue to go up too. And what are the 2 ways you can have your revenue increase? Get more customers, raise your prices. Consolidation gets more customers and gives you the leverage to raise your prices. One more thing about this is we say they don't have shareholders, but all these health systems issue bonds. They have bondholders. In order to get a good bond rating, what do you need? You need a lot of days of cash on hand. You need good market share. You need to be able to return value to the bondholders. You need to be able to service your debt. These are financial mechanisms and financial instruments that are driving the health system. They need to have leverage. They create this oligopoly so they can go and negotiate with these other for-profit, profit-driven organizations. And so you can see how this sort of spiral, or as John would call it, a flywheel, starts to happen. This slide's gonna seem super unrelated, but a quick alphabet soup here for how hospitals are actually getting paid. We have a couple of different things. These are Medicare related, but commercial insurers adopt them as well. So we have the physician fee schedule, PFS. We have the inpatient prospective payment system based on DRGs, which is how the hospitals are getting paid. We have the outpatient, which is basically the same thing, except less money because there's less overhead. So if you can imagine that, that's what sort of in the most simplistic terms, there's a schedule of fees for what the doctor gets paid, and then there's a schedule for what the hospital gets paid to cover, and we might talk about them like their facility fees is what people would commonly know them as. So here's like a quick example of what that looks like. Everybody with me? We're good? Yes. No one's getting too hungry? All right, promise, I'm trying to go. All right, so this is an example, very average example for a total knee replacement. So average charges of hospitals, if we just like look at hospitals, I think, forget where I got this number from. It might have been from one of your slides for Wisconsin. Average charges for a knee replacement are $49,000. Medicare reimburses a knee replacement at $13,000. You can also start to see why reference-based pricing can make a lot of sense. But the average commercial reimbursement is $33,000, and the average physician fee, which is what Medicare pays a doctor to do a knee replacement, is $1,300. So where, if you were a CFO at a health system, what would this graph tell you? Where are you going to focus your energy and effort to make as much money as possible? This line? This line? Or this line? Warmer, yeah, right? Hot, cold, yeah. You want the commercial reimbursement as high as possible. I'm going to sound like a broken record because I am one. How do you do that? You consolidate so you can gain leverage, so you can negotiate higher rates. It also shows you who's getting hosed in the situation, the physicians, and why hospitals retain so much power in the dynamic is because they want to drive this, so they're going to pay a physician more to stay there, sort of subsidizing this fee, if you will. And this low fee is also going to prevent physicians from going out, being independent, and doing their own thing in a lot of cases. It's not totally true. A lot of people have a lot of ways to make that not true. I know there's a lot of direct care folks here, physicians doing it, a lot of people, taking cash rates, and it's not like you can't go out and do something different, but these are the dynamics and the narrative that is told to keep doctors employed so they can generate these high dollar amounts so that they can keep growing and keep that profit level high. Okay, so this is your favorite health systems here in Wisconsin, and since it's your favorite, you're not allowed to be bored anymore, even though there's a lot of numbers on these slides. And these numbers are really to just tell a bit of a story and back up sort of all of this theory that I'm talking about. And it's kind of a thing, so gotta have some numbers. So this is UW Health. Anyone ever been to UW Health before? Anyone work there? Am I getting in trouble for this? I don't. Oh, okay. I am going to get in trouble. Yeah, this is all publicly available information. These are all from the financial statements for fiscal year 2024. And really what I want to show is, one, the magnitude, and two, the increases, and why this is going to be important. And I'll tell you like the take home at the very end. But for now, I'll leave you in great suspense with a lot of numbers. I'm not going to read to you, but you can kind of review them. I'll just point out some highlights. The highlights I like to look at in these kind of things, again, big numbers, right? $5 billion in revenue, that's a big deal. Hefty increases. And then these are always the most interesting things to me. Investment income, right? Investment value. When did delivering patient care become the means to an investment financial portfolio end? But when you create dynamics that require a public good to create as much profit and return as possible and get involved in all these equity markets, this is what happens. It'll be even more crazy when we get to Advocate Aurora. Yes, you're excited, I know. All right, so cash for the year, too. I mean, we talk about, and hospitals talk a lot about how they don't make any money. But UW Health made $467 million in cash at the end of 2024, which is up year over year, and great. They used $550 million in financing, and financing means they bought a bunch of stuff, capital, equipment, new hospitals, new this, new that. Why? Well, because if they're bigger, then they can capture more patients, and they can charge more money to the insurance companies, thereby keeping costs going up. And their balance sheet. So I'm not going to go through all these numbers, but you can just see, again, increasing year over year. That's the point. Every company wants to get bigger every year, right? More assets, less liabilities, but they'll take on liabilities to keep, the bonds, et cetera, keep funding capital improvements to keep growing. It's all a growth engine. And these are just some numbers taken from Q3, so a little more recent because they're one of those weird health systems that their fiscal year ends in June. So those numbers are like almost a year old. And where we're at. See, these hospitals like to say we're running out of money, things hard, but they have an 8.35 debt service coverage ratio. So their goal, and you see these numbers all the time, right? But where are their patient metrics? Where are their outcome numbers? Where are their who's healthy because they came here numbers? Those are the dynamics that we've created when these are now financial institutions that happen to provide healthcare and use the provision of healthcare as the means, not the end. Okay, advocate. Ben's psyched. Put away your phone. This is your part. I did this for you. Sorry. No, it's okay. I'm kidding. Huge health system, right? $16.8 billion. Now also merged with Atrium. I think it pushes that number into the high 20s, $20 billion a year. Investment income, $1.3 billion. Are these public good entities? Are they operating like them? Or are they operating like taking a public good and inelastic service and making as much money off of that as possible? Cash. All right, so they had a terrible cash year. It was down 57% from last year at $475 million, which means they made somewhere around $1 billion in cash last year. A lot of financing. These ones are super fun. Trading securities. That's investments, another word for it. Net. So they bought $9.7 billion in investments last year, after also making money off of investments, because that's a net figure. So again, just not to beat a dead horse, and not to just go through the accounting rules of these health systems, but to show and illustrate when the rubber meets the road, where the interests lie, what's being focused on, and it's a financial gain rather than some of the other things that we think healthcare ought to be. And in their balance sheet, $30 billion in assets. Things are going pretty well, I think, for Advocate. They make tons and tons of money, 94, plus percent, whatever. So now, who cares? What does this matter to me, to you? I know a lot of people in this room, you work for your brokers or, we're in the self-fund summit, and it's like, great, Preston, I don't care about economics anymore. You ran through those numbers. The world is terrible. What do you want me to do about it? So it's interesting for a couple of reasons. So this is a real picture of a hospital PR executive. I'm kidding. I got this off of like a stock photo or something. It's interesting, and I kind of gave it away, but hospitals love to cry poor. They love to say that things are so hard, we're not making enough money from Medicare, we take care of Medicaid patients, we need more, cost of staff has gone through the roof, help us, we need help, right? But we just saw all those numbers. How do you make $1 billion in cash one year and say, things are rough out here, we're not making enough money? Yeah, as a tax-exempt organization, yes. And so, how much tax savings too, right? They're not contributing meaningfully to the community from a tax standpoint, and they're using the community to fund all these other things they're doing. So that's why I think looking at the finance becomes really interesting and becomes really important. So last question that I'll ask you guys, and then also the sort of wrapping this up of what can you do about it. What do you see in this picture? You can shout it out. This is participation. Anybody? What do you guys see? Okay, what do you think a hospital sees? All dollars. This costs money, that costs money, her time costs money, his time costs money. That's probably the anesthesiologist. He's generating revenue. She's generating revenue. She costs money. That's all this is. This is a spreadsheet with dollars coming in and dollars going out. Because again, what's happened is because, and I like to reframe it, and again, I'm a little bit of a broken record, we have these economic issues or in the system foundation that it operates within to make it so that, to be a little bit forgiving, I suppose, they have to think about it this way. Because they have to issue bonds, and they have to take on debt, and they have to fight with United, and they have to come up to this table and do all these things. Is it all rosy and great and hospitals are like doing their best no. I'm not saying that. I'm saying we have to be aware of the dynamics. And being aware of the dynamics, I believe, puts you all in a much better position to choose, to advise, to broker. I don't know if anyone thinks about it like that, but of all these different things. And so there's two ways to look at this picture. It's either a spiral going down or it's a spiral going up. And it's up to, I think, everybody in this room and beyond, whether you're a broker, whether you sell a plan, whether you do plan design, whether you're a physician, whether you're a patient, everything, to decide whether we keep going up, because rest assured, we are going up right now, or we can stop it and start going down. I think the most exciting thing and why I get excited and maybe it's not all doom and gloom takeaway is that if we looked at the pie, like the biggest macro pie of healthcare spend, we really have government programs and then private, which is the commercial side. And then if we break that down a little bit further, we can see that employer spending on healthcare is about $1 trillion a year. That's a fifth of all healthcare spending. And that's a lot of leverage and that's a lot of power. Now, it's hard, right? Because employers don't want to change, there's a lot of inertia. You might have this small 50 employee company. You might have 1,000 employee. It's all over the board. But still, at aggregate, it represents a significant amount of dollars and a significant opportunity to start meaningfully bending the cost curve and trying to change from spiraling up to spiraling back down. And I think that understanding the dynamics of how the health systems are operating and how the insurance payers are operating, which is basically to say that both are incentivized to have healthcare costs go up. Because if you're a payer and costs go up, you raise premiums. And when you raise premiums, your revenue goes up. And when your revenue goes up, your stock price does better. And if you're a health system, you also want your revenue to climb. It's going to help you with your bond ratings. It's going to help you get more money so that you can pay your operating expenses. It's going to give you more cash to buy more investments. They're all incentivized for it to go up. And again, it's up to us, patients, doctors, plan sponsors, everybody, to start bending that cost curve down. That's all I have to say about that.
All right, we're gonna have some good Q&A chats here. And I'm gonna, while you guys are getting Slido ready, I hope you don't mind me ranting a little bit.
I prefer it.
Preferably ranting. The first thing is really back to what John said, is that calling out the behavior, not the individuals. We need health systems. We need health systems in American healthcare. So, the answer is not hospitals go away. That's not the answer. Should they change some of their behaviors? I think based on what we just saw and heard, absolutely, right? John gave you a story earlier about, the back surgery. And I think personally, I'm gonna ask Preston his opinion, but, consumerism, the market in which we operate in, right? Capitalism, free market. The more the consumer has the power and the choice and the insights, then they're going to be able to then help dictate the terms and bend the cost curve. Because you would never go to a burger place and pay, well, you never go in without knowing the price, but you never go in and pay $50 for a burger, that you could get for $10 at Culver's. That's just as good, unless the burger's got gold dust on it or something stupid like that. But that's the whole basis. So my philosophical question while they're loading up their questions is healthcare in America an actual free market?
No.
Is it a capitalistic market? Is healthcare as okay, you talked about philosophically the whole macro economic climate in America being capitalism. Is healthcare capitalistic for the consumer?
I guess someone smarter could probably have a better answer than me, but I guess it just depends on the way that you look at it. Because why I think it's more of an amalgamation and some kind of version of capitalism is because it's not pure free market. It's not just based on how you're performing and the best this and that. I mean, we have so much regulation involved in healthcare for a lot of the right reasons, but then you have these large companies that then are influencing the regulation and all this regulatory capture that is happening. So is it capitalism? I guess so, but our version is just, once you have the most money, then you just keep making more and more money as possible, which, so is it capitalist? I guess so in a way, but it's certainly not a free market. I wouldn't say that.
Totally. Yeah, well, I want to discuss that further with you.
That's probably a bad answer. But.
Yeah, it's an interesting, and a lot of what I'm trying to do, right, in my role is just simplify these complex ideas down for people to understand. And I think the easiest way that he was talking about hospital system generating revenue is the fact that a hospital system is not paid. I mean, they're paid by you, the employer, but how they think they get paid is from the insurance company. It's like a death triangle, right? So if they want to increase revenue, they send more codes to the insurance company to give them more reimbursements for the visit that they just had. John talked about Epic and about EMRs. Their whole purpose of existence is to maximize the revenue per patient interaction in a hospital system. So the more codes as a doctor I can put in here that sends to the insurance company means more reimbursement coming back to me, and I'm maximizing revenue doing that. Is that what's best for the patient? Right? You tell me. That's the simplified version of how I think about that process, right? So you've talked about it before. You didn't today about how we noticed, right? Out of that $50,000 knee surgery, do you see how much the doctor was making on that? People think doctors are making the vast majority of healthcare. In a $4.5 trillion industry, doctors and providers are making 7% of that. They're the ones providing the care. Where the frick is that money going? It's wild, right? So can you talk about doctor pressure, provider pressure? Hey, I only get paid if I do a knee replacement, and I'm only getting paid $1,300. So this is kind of a borderline case. You can see how these symptoms start influencing behavior, start influencing the incentives, and it makes it a greater misuse of what we're trying to accomplish here, right? So.
Yeah.
Can you speak to the doctor reimbursement issue?
Yeah, I mean, the doctor reimbursement issue is a huge issue. And so we can table for a second direct care and cash-based prices.
Yes.
And we just talk about the fee
contracted rates through insurance.
Right, contracted rates through insurance and fee for service. Yep. So, most commercial plans are going to follow what Medicare does. And so Medicare, year over year, has cut physician reimbursement. In 2026, they're going to raise it a little bit. Thank you, Medicare, finally, after years and years of cuts. So if we looked at a knee replacement, for example, and if just reimbursement for knee replacement had kept pace with inflation since the 90s, the doctor-physician reimbursement should actually be around $13,000 versus $1,300. And so again, and this is what is creating a lot of those issues where the health systems are becoming more and more powerful, especially in their regions, is because Medicare is budget neutral, supposedly, and so they look constantly from where to take the money from, and then hospitals, which has a huge lobbying arm, the AHA, and is going to go in and say,
American Hospital Association,
we're losing all this money, Medicare, you have to increase the inpatient prospective payment system and rates. We need it to go up or else we're going to go out of business. We don't have enough money, right? That's why they love to cry poor. So the Medicare looks and they say, all right, well, if we're going to increase here, where can we cut? And they cut from physicians. And that's how the power dynamic has shifted over the years, and a lot of reasons why physicians are increasingly employed by health systems is because if you just look at the numbers, the reimbursement, if you just operate in fee for service, it's much harder to be out and independent and on your own because you don't have the leverage. Medicare continues to pay less. Private insurers follow suit with that payment reduction. And the hospital says, great, they don't even notice that much the physician fee schedule. They just look at the total reimbursement that they're making. And then they're gonna pay a salary, which will, we can argue might be harder to make in independence than in the hospital. That's why you might hear people talk about health systems subsidizing physician reimbursement or physician pay. And that's why that's happening. Because they're looking at what they're totally making. And they're like, how much can we afford to pay the doctor? It's often way more. And there's a huge misnomer that physician reimbursement is like, someone slaps $1,300 in cash in the doctor's hand after a procedure and he goes home, right? If you're in independence, that's your revenue to pay your overhead and your nurses and your MAs and your EMR ridiculous costs, all of those things. So
that's why it's so hard to be an independent.
Yeah, and important too, because the more consolidation that happens, and the prices just keep going up.
There's a question related to that, but I'll get back to it because I don't know if Dr. Tim is in here. Is Dr. Tim in here? He might be out there with Solstice Surgical Center. So we work with a lot of surgical centers in the state that are offering fair cash pricing. And we hear all the time, how in the world can it be this much cheaper? Is because the doctors are not the expensive part of healthcare. Right. And Dr. Tim is hand choosing the best surgeons in the area to do these surgeries, right? Handpicked. He's an anesthesiologist. He's got practicing privileges in 11 different hospitals in Southeast Wisconsin. He's been around for a little while. I'm pretty sure he's done, tens of thousands of cases, knows who the best surgeons are. He's handpicking those people. He's giving them more money for the surgery, and then he's not marking up the facility fee that you saw in there. That's how he's able to do it, because he owns his own facility. That's how. So he keeps his facility fee net neutral. He doesn't make any money on it. He's just making a fair unit cost on the procedure, on the overhead, the equipment that they use, and then the surgery and the anesthesia. It's a beautiful thing when you see it all broken down and you can come to terms with that makes sense, that's a fair price. That's why it's so much less. It's truly remarkable that we can have higher quality care at such.
Imagine that.
Yeah.
Well, if you think about it, seeing your doctor is actually not expensive. No. But the healthcare system is wildly expensive. And it's all the junk in the middle. You said it, 7 to 8% goes to the doctor of $5 trillion. But $5 trillion doesn't happen without the doctor. How does that make any sense?
I say a lot that self-fund health, I mean, you could say we're a middleman, right? We're administering a plan. I mean, and here's the thing, is that what is healthcare? A relationship between a patient and a provider. And so the more we can put a patient and a provider together, or one of our nurse navigators with a patient and a provider together, and just get the heck out of the way, then really incredible things happen. And that's what we've seen in our experience. Really quick story. There's these 3 DPCs, direct primary care providers in the Twin Cities up by where I live. And one of them is actually my wife's DPC. And when they started their practice a couple of years ago, I was talking to him. This is when I was an advisor, so this is 3-4 years ago. And what they were talking about with the health system up there, about the pressures that they were facing and the things that they were told by the administration, literally made me want to throw up. Telling them that they were going to lose their jobs because they weren't bringing enough revenue. They weren't seeing enough patients. They weren't applying enough codes to every single visit to maximize the revenue. Because the office visit itself is what, $200, $250, right? But if we can get some diagnostic codes in there, if we can do some imaging, if we can do some labs, if we can do all these little things where we can mark stuff up, and that's ultimately why they left to practice in direct primary care, is because they literally, you could tell they were so beat up, they almost believed that they were piles of crap, not actually doing their job well enough. And they weren't even sure they could start a direct primary care practice. And I was like, it's insane how they were treated at this health system up there. And so it's real. Providers are faced with this. A lot of them are in cruxes in the road. And if you talk to these DPCs out there, just ask them, how many calls do you get from doctors on a weekly basis asking when you're ready for more patients? Because they're ready to go. It's 50% burnout rate right now for primary care physicians. Okay, which country today do you think has the best system?
Someone asked me that the other day, actually, and so my answer was I probably, unfortunately, don't know enough about other countries' healthcare systems to say which one I think it does. The two that always come to mind, and again, I don't know enough about it, but is the German healthcare system, and I think Nikhil mentioned it yesterday, is this healthcare system in Singapore, which tend to be much more interesting in trying to align. So like in Germany, they adopted like the Bismarck model, and there is insurance there, but it's all actual nonprofit. Like they are not allowed to make any profit. It's highly controlled and highly regulated. And I think, and yes, there are always trade-offs. I think at the end of the day, in other countries, you have a lot of different dynamics. And I think honestly, like the biggest one, so like one of the most interesting things I ever read about healthcare is that if you look at healthcare spending, right, we have the most expensive healthcare system in the world, right, per capita, and on a gross level. But if you define healthcare differently, we actually don't have the most expensive healthcare system in the world, because in France, when you define healthcare, it includes a lot of social services. And in different countries, and if you start to define it differently and look at it in terms of, education, safe housing, more economic opportunity, workforce development, all these different things that make health actually better, public health, imagine that. We're actually kind of in the low middle section of healthcare spending. So by our definition, we spend the most. By what should actually be the definition of healthcare, it is a little more commensurate with our outcomes. But the amount we're spending on the areas that really determine whether you're going to have a healthy society from a public health perspective, we spend the least. So it's a really interesting way, I think, to look at it and to sort of measure healthcare costs and what's a beneficial or appropriate system. Because I don't know enough about the dynamics, but there's other countries that we compare to, the OECD countries, they spend way more on actual things related to health, and it's designed in their culture.
Awesome, interesting. Okay, you mentioned RBP, so I want to throw out an RBP question. So for people that don't know, reference-based pricing, RBP, is a way for self-funded employers to try and dictate what is a fair price for services and only pay that. So he talked about Medicare allowable rates. In general, in Wisconsin, our commercial paying groups are paying to the hospital about 330 to 350% of what Medicare pays for the same service. And you saw that. The knee replacement with Medicare was 13, and I forget what the example it was, but 33. It was, yeah. So, you see that. It's 3.5 times what the government is paying for that literally the exact same thing, same surgeon, same whatever, same treatment, everything. Okay, so reference-based pricing is a way to say, hey, as a plan sponsor, we are only going to reimburse the hospital system 100. So there's no network, there's no PPO. We're only going to reimburse the hospital systems, let's call it 125% or 150% of Medicare, because they already take Medicare. So we're giving them 1.5 of Medicare. They should be really happy with that. But then what some hospital systems do is they say, no, because we know you're an employer, we're going to just make life so miserable for your employees, with the balance billing and all this other stuff, right? That, and sue them and take them to collections and whatever, that you're going to have so much flack and feedback and friction that we are going to make you hate your life and go back to a PPO commercial plan. Now, does RBP work? Yes, it works if you manage that friction well, right? Anything works. You get rid of your plan. That works too. It just depends on what kind of solution do you want as an employer. I, as an advisor, have done reference-based pricing. Self-fund health is not an RBP plan. And this is a huge distinction. I do believe that we are going to get to a place where we can get RBP type allowances, meaning we can get below that 200% of Medicare threshold while still working with a broad PPO that gives access to the hospital systems. That's literally how our plan is working right now, right? So when we say what's a fair price, we're basing it on 200% or less of Medicare. Is it as aggressive and as low as reference-based pricing? No, but we're getting much closer, and we're doing it with the alignment where we are inviting the hospital systems in to these conversations and these discussions, because there was another question of how are the hospital systems ever going to change their behavior when they are making so much money? And I mean, I'll answer later, but what is your answer?
Well, I mean, I think that it's hard, and I think there's going to be a lot of different reasons, and I honestly think that they're going to be forced to more than decide to.
Because?
That feels like a leading question. I mean, I think there's a lot of dynamics, right? Like as much as physicians are employed now, I think there's an opposite trend in sentiment for being employed. So more doctors are looking for different opportunities. And if, supply demand, if the supply is not there, then they can't continue on the way that they have. And I think that, again, this room, et cetera, there's going to be more and more employers and plans that are like, this is ridiculous. Like, we can't keep paying for this. I mean, we're at $5 trillion in healthcare spend. It's the largest employer of any industry in the entire country. More people spend on healthcare than on their mortgage on average across the country. Like, it's completely unsustainable. Something has got to give, and that upward spiral dynamic, I think, is the thing that is going to eventually give out. So I think they're not going to be incentivized. I think on the flip side of that, there are ways that you can incentivize them to change. One of those things, honestly, is maybe simple, but is speed. So I know everybody wants like the big check, right? Like we want the $33,000 in reimbursement from commercial, but like how long does United Healthcare take to pay? Is there any doctors in this room who like used to
months
look at and their receivables and be like, how long did United take to pay you? 180 days, like at best, right?
And what are they doing with that money?
They're
Investing
making more money on it. Yeah. But so if you can negotiate a much lower amount and say, yeah, but we're going to pay you date of service, and be like, okay, that sounds great. Why? Because now you can go put that money to work today. Like, talking to a CFO at a hospital, speed of cash and cash flow is more important oftentimes than what's going to show up on their income statement. Because like if you're on your balance sheet too, great. I don't know, my receivables are super high. That's an asset. But guess what? That's money you don't have, and you can't pay your nurses with receivables. You pay them with cash.
Well, a lot of manufacturers in the audience. Would you not love to receive your payment the day your product hits whatever customer bought it?
The day that it was made.
The day that it was made.
Imagine that.
How crazy would your cash flow be right now if that's how it would work? And would you not give concessions and be willing to negotiate if that were the case? It's no different with these systems.
Is that the right answer?
That was the right answer. Okay. Basically, what I was going to say is consumerism, right? You talked about free market, economics. Free market has turned into like sort of a political term all of a sudden in the last few years. I'm not talking about that. I'm just literally talking about if people had the choice, if they had the quality and the cost at the time of service in front of them, they would make the right choice. It's how you buy everything else in your life. We're just applying those same concepts into healthcare. That's why it works.